hear me? Water, mother. No, water. Who's going to Brazil? Who's going to Brazil? Hello, can you all hear me? Yeah, I welcome all of you. Can you hear me now? Is it okay? Yeah. Good afternoon. Actually, this PG clinical discussion is going to be telecast as part of the Indian Academy of Pediatrics PG student training initiative, which has been initiated by the President 2014, Dr. Vijay Vele, and it has been going on for the last, I think, 2 months, and this is the first time we are doing it at our hospital, Kanchi Kamakodi Child's Hospital at Chennai. And it so happened that there will be a clinical discussion, a case presentation, and this will be the discussion will be carried out by Dr. Vidyasagar, DNB postgraduate. Is it right, Kitty? Where is he? He's on the way, and it's actually a case discussion of an infant. This is telecast all over, and you can interact and interrupt at any time you like. You can ask questions. It's just like any other case discussion, right? Because this is directed towards the postgraduates at large, right? We are very happy that we are doing it for the first time here. This is going to be a regular feature from now onwards. In fact, Dr. Vijay Vale is planning in such a way that this will be done almost 2 or 3 days a week, non-stop for the next probably 1 year or even longer. This is being supported by the academic grant from Alembic Limited. And I've also been asked to announce that the next session is on 9th October. It's at 6 p.m. It's being the session is being held at Sion Hospital, Mumbai. Please note down. It's going to be done at 6 p.m. on the 9th of October at the Sion Hospital, Mumbai. And of course, all of you, I'm sure, how many of you have the downloading details? Yeah, it's there. If those who need it, we'll also give you today itself. At the end of the class, you can actually have a look at it. Kitty, the child is being brought down. Yeah, with the sister. Yeah. What's happening? You have the PowerPoint with you? Yeah. Huh? Yeah.
girl child brought by the parents hailing from Nellore, Andhra Pradesh. Mother provides a fairly reliable history with complaints of not gaining adequate weight since 6th month of age, and presently she is admitted for fever and fast breathing. The symptoms started 15 days back. Initially presented with fever and fever and fast breathing for 3 days, and currently admitted in KKCTH. Next.
So basically, what is the presenting complaint, Dr. Vidya?
The presenting complaint is fever and fast breathing.
Okay.
I'll do it. History of present illness. Mother noticed the child was apparently normal until 6th month of age. She was gaining adequate weight. At 6 months, her weight was 6 kg and a birth weight of 3 kg. Then mother herself noticed the child was not gaining adequate weight. She compared the weight with the previous 3 siblings. This is a 4th born child, and the child did not gain adequate weight as compared to her previous 3 siblings. And it was also associated with gradual thinning of all the 4 limbs with flailless. But the child interaction of the child with the siblings and her parents has been normal. In the current admission, the symptoms started 15 days back, which was characterized by fever, which was for 3 days duration, moderate grade, intermittent, and there is a documentation of 100°F by the mother. And the fast breathing started on day 2 of the fever, which is associated with chest retractions and difficulty in feeding. There is no previous history of any breathing difficulty, no history of any sucrose cycle or forehead sweating during the feeding, and mother also gives a history of intermittent cough, which is no diurnal variation, and intermittent episodes of noisy breathing. Moving to the developmental history, coming to the
before we proceed further, what is the primary problem for which this mother has brought this child?
It's fever and fast breathing.
You think that's the only problem, or are there more significant problems other than the fever and fast breathing?
And also failure to gain weight.
Which is worrying you more?
Failing to gain weight is worrying me more.
I think before you go into the developmental history of this child, you should elaborate more on the failure to gain weight.
Yes, sir. I have taken history for.
No, but I mean, you have moved out to, not that it's. I wouldn't say it's a mistake. They have moved out to developmental history straight away, without giving more details of that failure to gain weight,
yes, sir,
which is the primary or which is the most serious problem as far as I'm sure you're also concerned.
Yes,
yes,
yes, sir.
Yes.
So I've just taken a.
No, before you go to the negative history, I want more details. Can you go back to your presenting complaints?
Yes.
Presenting complaint. The primary first complaint you mentioned was that not gaining adequate weight since 6 months of age, isn't it?
Yes.
You should, whenever you present any child, you must take one issue after the other. The first symptom is not gaining adequate weight. You should go into the details of the second symptom only after finishing the first symptom in detail. Right? Can you elaborate more on that?
So this baby was born by normal vaginal delivery, birth weight of 3 kg, and she was on regular immunization follow-up.
You said that it was gaining weight
until 6 months of age.
I mean, as well as the other peers,
yes,
up to around 6 months of age. And you nicely mentioned that it was 6 kg at 6 months.
Yes, sir.
What happened after that?
Actually, what happened after that was mother herself says that she noticed the child was not gaining adequate weight as compared to her previous siblings of similar age, sir. And she felt that the appetite was normal, and she was also he was
so
also
very
eating
importantly
well.
You say appetite was normal.
Yes, appetite was normal.
Okay.
And she does not give a history of any loose stools, but mother says that immediately after giving each feed, the child passes a semi-solid stools.
How sure are you that the weight gain was poor? Sometimes mothers may give a wrong history. Even if the baby is obese, they may say the baby is not gaining weight.
This is the fourth born child, sir. The mother says in
Even a fourth born, the mother can
no, sir. This is in
need not be right. Even if the baby is gaining weight, say 200, 300 grams per month, for her it may be poor weight gain.
But she is clearly saying in reference to her previous three siblings, this child is definitely lagged behind.
Okay, okay. You have the mother has any numerical data on the weight?
Only the immunization card which they have, sir. That only gives the record of any weight given, sir. And at 9th month, when they went for their when they went for the measles and vitamin A dosage, the weight was 5.5 kg, sir, which was like
in other words, instead of saying poor weight gain,
weight is lost.
Weight was lost, isn't it?
Yes, sir.
Which is more sinister than
poor weight gain.
Lack of weight gain itself is important. Here is an infant who had lost weight, and when did it start losing weight? That's very important.
By the history, probably around after 6 months.
6 months. What happened after it? You said 4.5 kg at 9 months. Then what happened?
Then after that, though the mother felt that it is losing weight or it is not gaining adequate weight, she did not seek any medical attention, sir. Only once the child has developed fever and fast breathing, she had brought the child and the refusal of feed. She brought the child to medical attention in the first place, sir.
So you have no data on the weight after the
9th month measles immunization, sir. And after at that time,
do you have any idea about the weight now?
Yes, sir. It's 4.2 kgs. Sir.
4.2. That means it is actually weight loss.
Yes.
So your entire symptoms becomes more sinister. Weight loss starting from
6 months onwards.
6 months of age, isn't it? Right?
Yes.
Then one more thing is, was the weight loss acute, subacute, or chronic?
Chronic.
Did it occur over a few days, over a few weeks, or over a few months?
Over months.
4 months. It's chronic, isn't it?
Yes.
The whole thing has been slow, insidious, and chronic. Right. That is number 2. Yeah. Then go ahead. What else did you get?
No history.
You said appetite is okay.
Appetite is okay. No, definitely.
Was the appetite voracious? What difference does it make if you have 3 children? One child is losing weight, appetite is very low. Another child is losing weight, appetite is normal. Another child is losing weight, appetite is voracious. What is your inference? Anybody in the audience? There are 3 children. All of them are losing weight or not gaining weight. One's appetite is extremely good. The mother says the child is eating very well. Another mother says the child is eating normally. Another mother says child is not at all eating. What is your inference? Anybody?
Systemic.
The one with the normal appetite? Okay. Can you give an example of a child having a normal or above normal appetite still losing weight? Which disease?
Diabetes, hyperthyroidism.
It's a disorder characterized by inability to utilize the calories. In fact, the fundamental question is, when a child is losing weight, you should ask yourself the most important, losing weight and not gaining weight. Basically, it is failure to thrive, yes or no? For all practical purposes, this is failure to thrive. Your foremost question right in the beginning should be whether this is too little in, too much out, too little is utilized, or too much is required, isn't it? Which group do you think this belongs to from this history? That history should be very clear before you go to the next symptom.
Most probably it's too little in.
Too little in. You say appetite is good.
Even,
can you have a situation the appetite is good but too little in is happening? Yes or no?
Poverty.
See, all combinations can occur. I'll just give you an example. a child who has got an intestinal obstruction due to a mechanical cause, right? The baby's appetite will be okay, it won't be voracious, it will be okay. But because of the distension or the discomfort, the child might deny food, might refuse to take food. In contrast, a child who has got a local lesion which is painful or which is causing inflammation in the upper GI tract, just to give you an example, a candidial esophagitis, a CME esophagitis, a reflux esophagitis, the child's appetite will not be good. Child will refuse to feed, right? Or in a child, say, who has a chronic systemic disease like cardiac failure, child may be unable to take because of the discomfort associated with feeding. The appetite will be reduced. Or in a disease like, say, insulin dependent diabetes in a very young infant, how will be the appetite? Voracious. The baby will be very hungry, right? In fact, in general practice, if a mother tells you these days that the baby's appetite is superb, you should be more worried, isn't it? You should think of a storage disorder like glycogen storage disease, or a insulin dependent diabetes, or a disease in which too little is utilized when there is weight lost like this. Or in a situation like a cardiac disease or a chronic renal disease, chronic pulmonary disease, too much of calories may be required. So that concept is very, very important, and you should identify that before you go to the next symptom, right? So when you say lack of weight gain or poor weight gain, you must substantiate it if possible with numbers, rightly he compared with the other peers, and you must know when the onset was, how the onset was, slow or rapid, and what exactly is the reason, whether it is too little in, too much out, too much is required or too little is utilized. That is a fundamental approach when your mother gives you a history that the child is not gaining weight, right? Or sometimes, rarely, the whole data may be incorrect. She may feel the child is not gaining weight, but your growth charts might tell you that it is okay. Any of this can happen, right? Yeah. Can you give me more information? Then what is the associated symptom along with this poor weight gain?
Flailness and thinning of
the limbs with flailness. What does it mean to you? A child who is losing weight is becoming thinner and flail. What does it indicate?
Wasting of the muscles.
Muscle wasting is occurring. That indicates again the process is chronic. What about flailness?
Flailness may be because of the.
In a child who is losing weight, the limbs become flail. What does it indicate?
Poor activities.
Less active. Probably the muscle tone and power are getting affected. That indicates that the wasting is also significantly severe. And more so when he has said that at 6 months the baby was absolutely all right. And of course, he could have added one sentence, the infant was completely all right at 6 months, both in terms of growth and development. That would have added value to his statement of flailness. Suppose the flailness has been there right from birth, and it become more after the weight loss had started. It becomes a different story. There may be an underlying neurological problem with a nutritional problem or a chronic systemic disease. So, first sentence itself, you should have said that at 6 months was not only weighing 6 kg, but also was developing normally. I think that would have added much more value or power to his statement that this infant is becoming thin and flail. You all agree? Right. Go ahead. No, still some more information. At this point, you please don't go to the fever business. You go to the weight. What else other than this you would have asked? At this point, what other questions you would have asked the mother?
Vomiting,
loose diarrhea. Of course, he has got a nice slide. Go to the negative history. Negative history. He has got, yeah, please tell me now.
There is no, similar complaints was related to the fever and fast breathing, sir. No,
So, for this weight, you didn't put any negative.
Yes, sir. No history of any vomiting, no history of diarrhea.
Yeah.
There is no history of polyuria or excessive thirst.
Mm.
There is no history of any recurrent skin infection or ear discharges. There is no previous hospitalization or any history of suggestion of any altered sensorium or seizures.
Mm. Mm.
No other.
No. Some more. What other points you would have listed? He has given fairly good information. He said there is no diarrhea, vomiting. Indicating that too much out is not happening in the GI tract. Too much out is not happening in the renal tract. Infection part, he says no infection, no hospitalization. Indicate that this is not likely to be a chronic systemic disease which had been in operation for a long time. CNS is essentially okay, and he had also said, I think development was normal until 6 months. Any other?
Diet given.
Pardon?
Diet intake.
Yeah, he is going to give much more details in the diet. Anything else? Pardon? Yeah, okay. Any respiratory distress, okay. Fast breathing, okay. He said succrose cycle already. Anything else? Anything else? I think most important information other than this is the presence of edema. I think you should have a child who is becoming chronically malnourished, edema history would have been very relevant. More so because edema would tell you that the edema might be nutritional or it may be a loss in the GI tract. Sometimes you may have edema in states such as intestinal malabsorption without diarrhea. And most notable example being protein losing enteropathy. Protein losing enteropathy. In protein losing enteropathy, you might have edema even without the parents complaining that there is diarrhea. That would have become very relevant in this presence of edema. Okay? Right. Go ahead.
Shall I elaborate on the?
Yeah, go ahead. Go ahead.
So 15 days prior to this, child initially developed fever, just 3 days duration.
And of course, I'm sure he is going to tell us. You should also say what has been the medical intervention so far. What has been happening? 6 months. You very rarely come across a mother who does not seek medical attention and something like this is happening, right? Right.
Fast breathing started on day 2 of fever, which is associated with the difficulty in feeding and chest retraction. No history of succrose cycle or forehead sweating during feeding. History of intermittent cough during associated with the fast breathing. It had no diurnal variation, and baby had intermittent episodes of noisy breathing in association with in addition to the fast breathing.
What does this history tell you?
This is
how do you interpret this history?
This is an acute infection, sir. In addition,
acute
lower infection, probably pneumonia, sir.
Acute infection. Where is the infection?
Lower respiratory tract infections.
Why do you say lower respiratory?
Because of the fever, fast breathing, and retractions.
Retractions.
And poor feeding, inability to feed.
Poor feeding. Why not this be an acute cardiac failure? Myocarditis. After all, he has written short duration fever, and fever was there for a day. On day 2, the child started having
difficulty
fast breathing and also chest retractions and poor feeding. No history of succrose cycle or forehead sweating. History of cough is there, no diurnation, had noisy breathing. Is cardiac cause ruled out? Is cardiac cause ruled out?
No edema.
No edema.
No.
Dr. Kirti says there is no edema, cardiac cause is ruled out. Okay, fundamental point you must remember, in younger children, edema is a very late sign of cardiac failure. And even if edema is present, the edema is sometimes not recognized either by the parents or by the doctor. Because in young infants, edema may be there in the sacral region. How many of you examine the sacrum for edema? You miss it. One. The mother might not recognize edema. Third is, edema is a late sign. In fact, if you find edema in a child with cardiac failure, that means the child is in the popping crease, very seriously ill. It's unusual for a right heart failure to present with edema in young children. Older children, adults, yes, not a very reliable. So somebody, suppose I ask you, which is the most important symptom of cardiac failure in pediatrics? Excessive cry, no. Fast breathing, tachypnea. Tachypnea is the most sensitive symptom of cardiac failure in young infants. Of course, followed by, of course, feeding difficulty. In fact, you could have asked about the posture of the child during sleep. That is very important. The same mother gives you a history that the infant is unable to sleep flat. What does it mean? It could mean orthopnea. That is very, very important. It is not simple. It is not enough if you say only difficulty in feeding. You should describe more. And the whole noisy breathing may be because of pulmonary edema. You never know. Right? Said some noisy breathing is there. Cough is there. No diurnal variation. What do you think this child is having? Of course, from your side, there is no orthopnea, isn't it? There is no orthopnea. There is no edema. There are no precordial pulsations, right? So it looks likely that this is an acute respiratory. Is it a chronic respiratory problem or an acute respiratory? Looks like an acute respiratory problem. Since it is there with fever, it tells you that, I mean, you get information that this is likely to be a infection. Third, as he rightly said, he said lower respiratory infection. And of course, I asked him what it is. What lower respiratory infection is this? Probably pneumonia. How many of you think this is pneumonia? Yeah. Pardon? Only the minority support Vidyasagar. Majority are not lifting their hands on pneumonia. Why do you think this is pneumonia, Dr. Kirti? So the infant is failing to thrive, who has fever, fast breathing, retraction. The commonest thing is, like, I agree. But why do you have noisy breathing? And what noisy breathing you get in pneumonia, Vidyasagar?
Probably it's maybe a grunt.
Grunt. Okay. So again, you should have described what noisy breathing is said. Again, don't go by, see what the parents say. Parents will say cold. So parents will say phlegm. So you must ask them to describe what it is. For example, if they say noisy breathing, the noisy breathing may be, just to tell you, one, it may be a snuffle due to an obstruction in the nose, or maybe a snoring, which all of us do in the afternoon's class, okay, due to obstruction of the oropharynx, or it may be a stridor due to obstruction of the larynx or trachea, or if there is an obstruction or if there is a lesion in the carina, what do you call it? Rattle. Okay, you can have a rattle which is produced by secretions accumulated at the carina, and it is supposed to occur in children who are neurologically impaired, who have neuromuscular disease, because of their inability to clear secretions, or it may be a wheeze due to obstruction of the intrathoracic airways, or it may be a grunt, which is nothing but a positive end expiratory pressure, PEEP, which occurs in pneumonia, right? So these are all the types of noisy breathing. So what noisy breathing did this child have? Yeah.
Probably grunt.
Probably grunt. Okay, which you could have described whether the child was producing noise during expiration. You could have actually shown the mother what is grunt and asked her, right? That would have been very, very useful. But in all probability, this looks like a lower respiratory infection. Extremely unlikely to be a wheezing associated. I mean, it can be a viral respiratory infection also. You never know. but the first episode occurring in a child who's failing to thrive, this could be pneumonia, right? Next one. And again, do you think this pneumonia, whatever lower respiratory infection, when you say lower respiratory infection, you always know that it is an infection occurring at the larynx or below the larynx. In this child, where do you think? You think it is probably occurring in the parenchyma or in the airway or in the pleura or in the trachea?
Parenchyma.
Why do you say parenchyma?
Because of the intercostal and subcostal retractions.
Yeah, the retractions are present. The only red herring is this. He said history of cough. He didn't describe more in detail. If cough is more, it is very, very unlikely
Cough is
to
not
be
the
a
primary symptom, sir. Fast
cough.
breathing
Very
was
good.
the primary symptom.
The primary symptom was not cough. You see fast breathing, then some cough is there. So this indicates that this could be a parenchymal problem, right? It's likely to be a parenchymal problem. If it is parenchymal problem, the next question Vidya should have asked, what question he should have asked? Whenever you say parenchymal problem, you should have identified whether the problem is, can anybody complete? Unilateral or bilateral? How? Postural variation. The way the child was sleeping during the illness. For example, if there is a pneumonia on the right side, the child will splint by sleeping to the left side. Or if there is a massive pleural effusion on the left side, sleep on the left side. Localization of the lesion is possible even if it is pneumonia. You can identify whether it is likely to be bilateral or unilateral with questions related to disturbance of symptoms in relation to posture. Right? Go ahead.
Following this, the child was brought to Child's Trust Hospital, where in the emergency room,
can you have some video in between? Video is coming, or you are showing only PowerPoint now? Okay, fine. Yes.
Following this, the child was brought to the emergency room of Child's Trust Hospital, where the parents were told that the child is having very severe infection, and it was shifted to the PICU for further management, where the baby was mechanically ventilated for 4 days, following which baby was removed from weaned off mechanical ventilation and shifted to the ward by day 10 of hospital stay. Now currently, and during the PICU stay, in addition to the ventilation, child was treated with antibiotics and other supportive medications. Currently, child is continued on IV antibiotics, and NG feeding is being given through the nasogastric tube, and child is still on 2 liters of oxygen, which is being given through a nasal cannula.
So obviously this child has had a severe lower respiratory tract infection, probably a pneumonia, has gone to the ICU and come out, and it is definitely improving, but it is also still
having
oxygen dependent right now, but it is much better than
what it was.
Right.
And parents also feel that the child is improved since admission, in the form of improvement in sensorium, interaction with the parents, and definite reduction in the rate of breathing and also the child's activities. Now I am moving to the developmental history.
Can you look at the negative history once more? Okay, right, fine. Go ahead.
So gross motor.
Next, how will you start after this present history, and you will start with the antenatal history or straight away go to the development history? Antenatal, go to the antenatal history. And this is just for discipline in your exam presentation, right? Fine.
Antenatal history. This is the
anything significant?
No significant. This is the 5th conception of the mother. First,
in a child with failure to thrive, what antenatal history would be important to you?
Spacing in between the births.
Good. Close
Multiple
spacing
births
will always reduce the weight of the newborn one. Yes.
Weight gain mother during pregnancy.
Weight gain during indicating that there is intrauterine growth retardation. The weight gain is inadequate. 2, 3.
Any antenatal infections.
Any infections.
Nutritional supplements during pregnancies.
Diet of the mother, right?
Just multiple gestations.
Multiple gestation can result in IUGR and failure to thrive. Drugs also. Many drugs can produce intrauterine growth retardation, which starts from diphenylhydantoin to alcohol to smoking to marijuana, anything. All these chronic drug administration, the mother can result in intrauterine growth retardation, right?
Prematurity, IUG,
Yeah, prematurity resulting in
pregnancy-induced hypertension.
yeah, chronic illness in the mother, right? Infections complicating pregnancy, hypertension, all these could have, nothing is there in this child,
No, sir.
right? Fine.
Only significant is the mother had an abortion for the third baby, which was after the second pregnancy, and it was medically terminated at 4th month because the baby was told to have a brain-related issue, probable
Fine,
hypertension.
fine, go ahead.
Natal and perinatal history. Baby was born by normal vaginal delivery. Term baby with a birth weight of 3 kg. Cried immediately at birth. Was breastfed within half an hour of birth, and there is no history of any NICU admissions.
So essentially normal antenatal and neonatal history, right?
As I said, this is the 5th born to 3rd degree consanguineous parents. She is having 3 normal siblings. First sibling is 10 years girl child. Second is a 7-year-old girl child, and the immediate elder sibling is a 4-year-old boy baby.
This is a girl, is it?
This is a girl child,
Yeah,
so 1.5 years old girl child.
Okay,
So spacing appears adequate in between birth.
fine,
There is history of one abortion.
fine. Except consanguinity, that doesn't. There is no chronic illness in the family, either in the sibling or anybody, right? There doesn't seem to be anything significant in the family history other than consanguinity. Okay.
Sorry.
Development. Now go to the development. Yeah.
Yes. Development. Gross motor. Baby achieved head control at 6 months. Rolled over by 7th month. And currently, it is only able to sit with support, which was achieved at 10 months of age. And fine motor, baby started to grasp at 6 months, able to reach and transfer objects by 7 months, and is, as per the father's description, if you give a pen to the child, she is able to hold and scribble on a piece of paper, and child is able to wave bye bye and recognizes the parents, and as per father, he is able to say baby was able to say bisyllable words like amma and appa. So
What is your inference from this developmental history? Is it complete?
it's predominantly a gross motor developmental delays.
Predominantly. When he says predominantly, it means that others are also abnormal. Is it?
No, sir. Others are normal.
Then why do you say predominantly motor? You say?
It's a gross motor
No,
development.
I want to know from your developmental history whether the first is the development normal or not. First, is it normal or abnormal?
It's abnormal.
Likely, definitely it looks like it is deviating from normal. Okay, instead of saying abnormal, you can use the word deviation or delay, right? So definitely there is some delay. The next question is there global developmental delay or isolated delay in one of the 5 domains of development? What is happening in this child?
It is an isolated development of gross motor milestones.
There appears to be an isolated gross motor developmental delay as per Vidyasakar. Now, if it is isolated gross motor development, are all the domains normal in this child? Other domains?
Yes, sir.
In other words, what are the domains that you assess when you take a development history?
Gross motor and fine motor, language,
Is
personal,
gross
social,
motor
and
and
cognition.
fine motor taken together or given
Separately. Given motor is a single component, sir. Gross motor and fine motor should be taken separately.
gross motor and fine motor are taken together one. Then
Gross motor, language, personal, social, and cognition.
is language development normal in this child?
Yes, sir.
It looks normal, isn't it? 15 months old, isn't it?
15
months
old.
old.
1.5 years, sir.
Is saying amma appa.
Yes, sir.
At least a few words with meaning it is saying. Right, fine. Language development. Of course, you can't say that just because the baby is speaking only 5-6 words is abnormal. It looks overall okay. 1, 2. Next, what are they?
Personal, social, and
Personal, social. Yeah.
and personal, social is able to recognize parents, interacts with the siblings.
Okay.
Vision appears.
Okay. Personal, social appears to be okay. What about adaptive?
Adaptive.
And cognitive. And
Response.
bowel bladder, sleep. Bowel bladder is important, isn't it? Huh? Is it important or not, bowel bladder? But in a child whose failure to thrive, sometimes you may not get history of polyuria in the original history, but here they will say child is passing urine 20 times, 30 times. So here again one more way of asking for history regarding abnormalities in bowel and bladder will be here even once more in the development. You can ask them whether the baby is passing urine too frequently. Could have asked that question. Is it there in this type?
No, sir.
Not there, right. So essentially this is a motor delay, and motor delay, is it fine motor delay or gross motor delay, or both are equally affected?
Gross motor.
Hmm?
Gross motor.
It looks like gross motor because you nicely said that it is scribbling and holding pen in spite of being flail, indicating that it is gross motor which is affected, right. What are the conditions in which gross motor development alone is affected without any disturbance in fine motor, any disturbance in language, any disturbance in cognition? Anybody in the audience?
Vitamin nutrition. Vitamin D deficiency.
Yeah, if gross motor alone is affected, it indicates that it is likely to be a neuromuscular problem. Neuromuscular problem, particularly as somebody was murmuring in the back of the hall, likely to be a proximal muscle weakness, and if it is a distal muscle weakness, necessarily it will interfere with fine motor development, and proximal muscle weakness obviously is often associated with myopathy or sometimes in rare forms of neuropathies. So in general it is likely to be a neuromuscular problem. This is not something which is affecting the cerebral cortex. If fine motor is not disturbed, other domains are all right, it is likely to be a neuromuscular problem which is likely to be proximal, right. It could be a muscle disorder. In a child like this who's failing to thrive, if gross motor is affected, what is the likely inference from you?
New chronic illness.
It could have been due to the chronic illness per se causing muscle wasting, malnutrition, resulting in gross motor delay, right. Okay, next. Yeah, please. Yeah, it is important. Of course, history, everything is important in history. This history of dysphagia is important in the sense, how is dysphagia, how is, suppose the same mother had given you a history that there is dysphagia, what would have that, what information you would have had from that?
It would have indicated a neuro dysfunction.
Dysphagia means, see, it is not only dysphagia, disturbances in dysphagia as well as odonophagia. See, for example, when you say dysphagia, it indicates, it may mean so many things. It may indicate that there is some mechanical obstruction. For example, if you have a 2-year-old, 3-year-old child who's not gaining weight, it may even indicate a adenotonsillar enlargement which can cause dysphagia or odonophagia. Or you may have a disturbance in the nervous system in the form of disturbance in coordination and power in the oropharyngeal musculature, which could indicate a chronic neuropathy or a chronic neuromuscular disease. Third, even in a spastic child, like for example a child who has got cerebral palsy, a pseudobulbar palsy, may have spasticity of the bulbar musculature resulting in dysphagia. Last but not the least, even in a child who does not have a neurological problems, there may be a local problem. For example, palatopharyngeal incompetence, velopharyngeal incoordination, or a child who has got anomalies in the upper, in the mouth, which includes cleft palate, posterior submucous cleft palate, peri-Robin. All these can produce difficulties in swallowing. That history is certainly important, right. But he said the appetite was good and child was able to swallow. Of course, he didn't specifically mention swallow, it is important, right. Go ahead. Yeah.
moving to the dietary history,
Yeah.
child was exclusively breastfed until 5 months of age, after which mother started initially the child on idli, rice, dal, and also biscuits, which were introduced in a sequential manner. And child is yet to be started on any non-vegetarian food, and including egg also, though the family consumes a mixed diet.
What is the ideal age to introduce non-vegetarian foods?
Beyond 1 year.
1 year, by and large 1 year, right? Fine.
Calculating the calorie and protein gap, child was given 635 calories against an expected of 1600, with a calorie gap of almost 1000 kilocalories. Protein was 15 grams against a requirement of 16.5 grams, with it's a mistake, 1.5 gram gaps. It's a typing error. Child was given vitamin supplementation, with the details of which is not available, but mother says clearly the vitamin A dose was given along with the measles vaccine at 9 months.
Right. Now, what is your inference from this dietary history? Anybody wants more information from the dietary history? Anybody in the audience who is not satisfied with whatever Vidya got it? Don't use the term weaning at all. Many examiners object to it. You say complementary feeds, right? The modern trend is not to wean away from breast until 2 years and longer, right?
Amount.
Okay. Any other comments on the dietary? Any more information? Okay. Okay. I am going to ask a question to Vidyasagar. In a child who was normal completely until 6 months of age, 6 kg, you have documented it was 6 kg, for all practical purposes, which was developing normally, growing normally, some trouble had started at 6 months. What specific dietary history one should elicit?
Whether she is continuing to breastfeed the child.
Pardon?
She is still continuing to breastfeed.
To me, the most important point in the history is history related to the possibility of food allergy or food intolerance. Just to give you an example, an exclusively breastfed infant who is completely normal at up to 6 months, suppose the child starts losing weight or not gaining weight and vague symptoms of vomiting, vague symptoms of cough, wheeze, rash, what do you think of?
House milk protein.
House milk protein allergy. Similarly, if a child is from an North Indian background, some solids are introduced, child starts getting abdominal distension, pallor, celiac disease. I think these two disorders must be kept in mind in this child, right? So, it is not enough if you simply mention the calories and proteins, you should specifically mention whether the symptoms are related to the introduction of a particular food substance in this child. Was it there, Dr. Vidya?
No, sir.
It was not there. It is not there, but that is very, very important, right? That is important in this child. In addition to that, you should also find out if for some reason the mother had withheld calories and proteins wrongly. It can happen. For example, the mother might feel the abdomen is getting distended and we might have denied so much of calories and protein, whether that was there, right? That is very important in this child.
Mother noticed abdomen distension, sir, but she didn't withhold any.
Now Vidya is letting the cat out of the bag. He is now saying abdominal distension. Initially he didn't say. If he had said abdominal distension, you could have localized the entire problem of failure to thrive to a cause operating in the GI tract, which is now involving the respiratory tract, isn't it? Okay, fine, doesn't matter. Go ahead. So this diet tells you that this child is completely normal. Something had happened between 6 months and 15 months. There is no definite history of vomiting, diarrhea, rash, wheeze, cough, choking. Nothing seems to be happening. Obviously, the child is not getting enough. That indicates that the calorie gap is very, very significant, isn't it? It's getting only how did you calculate 1600 calories? No, you have put 635 against 1600. Is 6,600. Is that the requirement for a 15 months old child? How did you arrive at that figure?
First 1000, sir.
1000. You have put 1600.
1.5. 1 year and 6 months old.
Huh? At what age is 1600? How much do I require?
2000.
How much do I require for living well?
2500.
2000. How much does a 1-year-old child require? It requires half of it. So at 1600 is a requirement of a 6 to 7-year-old child. It's a mistake. It requires only 1000 to 1100 calories. 1600 is impossible. Child will become obese. Okay? Impossible. Probably you calculated 350 calories per kg, isn't it? That is a catch-up growth. So this requirement is only 1050 to 1100 calories. Right? Too much. Obviously there is a calorie gap of approximately 350 calories. Proteins seem to be adequate. Again, was on vitamin supplements, detail not available. Which vitamin supplements are relevant in this child?
Iron, vitamin D, sir.
Which are the vitamin supplements that are relevant in this given case?
Fat soluble vitamins, vitamin D.
Fat soluble vitamins, particularly A and D, are very important in this child. More so because there appears to be a chronic wasting disorder in which A becomes important, and there appears to be, why D becomes important? Remember, somebody will say, when wasting occurs you don't require vitamin D, isn't it? Vitamin D deficiency is very rare in marasmus and kwashiorkor. That is what we have all been taught, isn't it? Why?
Growing.
Yeah, it is basically a disorder of a growing child. So when the child's growth is arrested due to chronic malnutrition, you don't get rickets. But that myth is now exploded. In fact, there are enough articles from Africa in the Journal of Tropical Pediatrics that rickets can occur in severely malnourished children. Because they are not very common, but it can occur. Because the rickets is mostly due to calcium deficiency rather than vitamin D deficiency. That's a new concept which is there. That is one. In this child, vitamin D deficiency is important more because there is definite motor delay. Isolated motor delay has to be thought of in addition to neuromuscular problems, a nutritional problem like rickets. So vitamin D deficiency, vitamin D supplementation or lack of supplementation, exposure to sunlight is very important in this child. In addition, in any neurological problem, of course you should elicit history of risk factors for vitamin E deficiency, which can occur in children who have got which disease? Vitamin E deficiency. Which chronic systemic disease is prone to liver disease, cholestatic liver disease. Notorious. Vitamin E deficiency is notorious. Don't you supplement vitamin E for those with cholestasis? Very high, 50 units per day we give, isn't it? Right? Vitamin K, and if the child is purely vegetarian, there is also a risk of megaloblastic anemia due to B12 deficiency. And if the child is not being in enough vegetables, which vitamin deficiency is likely to occur? Not given vegetables. Only area where vegetarians are at an advantage over non-vegetarians. Folic acid. B12 is for non-vegetarians, folic acid is for vegetarian. That is very, very important. And suppose this child has got vitamin, yeah, please, what is the question? If failure to thrive was about cognitive function, wouldn't be affected because micronutrient deficiencies can cause it. How do you answer this, Vidya? He says, the viewer says that failure to thrive can affect cognitive function. Yeah, you can have cognitive dysfunction even in a child with failure to thrive. For example, studies have shown that children with chronic protein energy malnutrition, their cognitive function is definitely affected. Long-standing protein energy malnutrition, Dr. Gopalan has clearly shown it can result in microcephaly. It can result in impaired attention span. Number 3, in children who have got failure to thrive, for example, in infancy you may have what is called, it's not common in the south, in north it is very common, infantile tremor syndrome. It can cause tremors, motor disturbance, involuntary movements in addition to cognitive dysfunction. And you can have cognitive dysfunction in children with micronutrient deficiencies such as B12. But it's not very common. It's not very common. However, that has to be kept in mind. In this child, there doesn't seem to be much of affection of cognitive dysfunction. Yeah, go ahead. Next. So that's regarding the diet history. Right, next. One thing, there are 2 important points in the diet history. You must find out why this child is getting less. Is it because the mother is not giving, or because the child is not taking, or is it vomiting everything and the mother is not giving? Some reason. In this child, there doesn't seem to be any of those things. The baby is taking only that much, isn't it? So your statement that appetite is good probably is not likely to be right. Fine. In addition, you must find out that the diet is balanced. Why is it important? For example, this 1-year-old child, the mother is giving only 800 ml of milk or 1 liter of milk and providing calories, 1000 calories with sugar and getting enough protein. That's not balanced. So you must find out whether the diet is balanced. For example, a 1-year-old child should take 20 grams of protein and 1000 calories with balance of cereals, okay, legumes, pulses, leafy vegetables, fiber, etc. Right.
Immunization, child is immunized up to 9th month as per national immunization schedule. Socioeconomic status, they belong to the lower socioeconomic class as per the modified Kuppuswamy scale. So I like to summarize my.
You got a slide on summary?
No, sir, I didn't.
You don't have. Can any volunteer from the audience sum up the salient findings from the history and give a probable diagnosis? Anybody? Don't volunteer, I'll have to pick you. Pick somebody. Yes, Shruti. You're there from the beginning, no? Right. Unfortunately.
A 1.5-year-old male child born fourth to a
Go ahead.
1.5-year-old female child born fourth to a consanguineous marriage is brought developmentally normal and gaining weight well up till 6 months of age. Is brought with the major complaints of losing weight over the past 1 year, and she and with a current history of a lower respiratory infection. She has no substantiating history for any chronic illness.
Okay, right. Okay, let me put it this way. I think I can give an exercise to the student. Can you all write what are the points? Suppose you see in the exams or perhaps even in real life, before you start examining the child, you must have some idea about the working diagnosis. You must know what to look for in the physical finding. So with this in mind, can all of you write, at least a few of you can write, which are the salient points in the history which is importantly positive, which are importantly positive and which are importantly negative. Please write. I'll give you 2 minutes time. Any questions from it? Just to get up 2 minutes time, you can all write down the essential points in the history which are giving a clue to the diagnosis. Vidya, what do you think are the essential points you feel that are important? Give the mic to the audience.
One thing is that child is normal until 6 months. Then only
very important. This child was extremely normal, both growth and development. Of course, One thing Vidya did not mention. What did he omit in the growth? Anybody can tell me? What did he omit in the growth? What did he omit in the growth? What are the parameters you normally you check to assess growth?
Head size.
Weight, length, and of course head circumference. Is that important in this child?
Yes.
Yeah. How is it important? Can you give an example of the head circumference becoming very important in a child with failure to thrive? Simple logic. If there is hydrocephalus, the head would be large right from birth. That will explain everything that is happening in the baby, isn't it? The weight can be normal and may start losing weight with or without vomiting afterwards. Or it may be a microcephaly indicating severe intrauterine growth retardation. So head circumference should have been inquired into. Even the length would have been important. For example, if a baby has chronic malnutrition, it is likely to affect the length much more than weight. Right. So you think there is some disturbance in the growth of the child affecting mainly the weight. It is essentially normal up to 6 months. What else did you infer? What else did you infer?
Then gradual reduction in the activity.
Gradual reduction in the
Activity of.
yeah, affecting the gross motor development, right? Then
It is like predispose the child to infection and.
predispose the child to. You think this chronic illness was responsible for the pneumonia or it is incidental?
Incident.
Do you think this acute respiratory infection is incidental or is definitely related to the chronic illness?
It is related.
Simple logic. In a normal child, if there is an acute pneumonia or an acute lower respiratory infection, you expect the child not to go to ICU, isn't it? Unless somebody doesn't treat properly. This child has gone to ICU and has come out of it and is still oxygen dependent. For want of time, I didn't go into the details of oxygen dependency, etc. Right? Okay, this child is still not completely all right. As per Vidya, the child is continuing to have tachypnea and retractions, indicating that the problem is persisting. So now you tell me whether the underlying problem is related to this problem or not. Definitely yes. Yes, definitely yes. There is a significant lower respiratory tract infection, probably infection, which is taking long time to improve, right? And still the child is oxygen dependent. What else did you infer? Yeah. Okay, pneumonia, and his child is still requiring oxygen. What does it imply to you?
It is a interstitial.
See, basically, if you have a child who is coughing profusely, who has a noisy breathing, right, who does not have cyanosis, who does not have much of fever, who has productive cough or a moist cough, right, it is likely to be a chronic or acute airway disease. On the other hand, the child is going to have significant retractions without much of cough, without noisy breathing, and if there is cyanosis, right, and if there is dependence on oxygen, it is very much likely to be a alveolar problem or an interstitial problem, right. So now what is the duration from the time of the beginning of this event till now? How many days?
15 days.
15 days, is almost 15 days. Do you expect a child with a simple lobar pneumonia to require oxygen for 15 days? Unless it is having some empyema thoracis which is very big or bilateral pneumothorax. Otherwise, you don't expect a child with a simple pneumonia. So this pneumonia is likely to be something which is interstitial, isn't it? Cough is the child coughing now, Vidya?
No, sir.
Not coughing now, it tells you that this is likely to be an interstitial pneumonia, right? What next? We have not still got to the bottom of the problem. This child, we said, there is some arrest in the growth and it is losing weight. What is causing it? Still, I am going back to my own question. Too little in, too much out, too much is required, and too little is utilized. You must all be fed up listening to the same 4 questions. Huh? Most likely, this is likely to be something which is too little in, too much out cannot be ruled out. Cannot be ruled out, because Vidya said there is some abdominal distension, though there is no diarrhea. Though not diarrhea, how many stools is the child passing?
5 to 6 episodes.
Right. It could still be some form of partial malabsorption. Malabsorption might exist, or it may be simply be too little in, which has caused the problem. Right? Too little in causing like this is very, very unusual. There must be something more if the abdominal distension had been there as per the history. Right? Then the next question is, if it is too little in and probably too much out, pathology. Where is the pathology? For this failure to thrive, where is the lesion?
Gastrointestinal.
Most likely to be in the gastrointestinal tract. If it is likely to be in the gastrointestinal tract, which part of the gastrointestinal tract is likely to be affected?
Small intestine.
Why say small intestine? Abdominal distension. Abdominal can occur in lower intestinal problem also, no? Yeah, there is no constipation. As per the history, there have been no visible loops. Of course, any such negative points could have been very, very relevant. In fact, even abdominal distension indicating whether it is on the right side or left side, indicating organomegaly, would have been relevant. So, you expect this child to have failure to thrive with growth retardation. You expect the child to be spastic or hypotonic? Hypotonic with severe muscle wasting, and you expect this child to have some features suggesting interstitial lung disease, and you expect this some clues from the physical examination regarding the cause for the failure to thrive, isn't it? Right. Let us proceed to examine the child.
General examination. Child is
Get the child, Kirti. Yeah.
Child is examined on the mother's lap. It's chronically ill-looking, lying supine on the mother's lap with abducted and externally rotated upper limbs with partial flexion at the elbow, external rotation and abduction at hip, and flexed knees. He has visible wasting and visible loose skin folds in the axilla, gluteal, and also even the buccal mucosa, buccal region is wasted. He is dyspneic at rest, receiving oxygen by a nasal cannula oxygen at 2 liters per minute. Nasogastric tube is in situ. IV axis is seen in the dorsum of the left hand, and the right hand is covered with a plastic wrapping material, which the mother says it is meant for a investigation. There is pallor, no cyanosis, no clubbing, no lymphadenopathy, no edema or icterus.
Always don't say no lymphadenopathy. No lymphadenopathy means that you must think of T-cell deficiency.
Significant
the extremes of malnutrition, you may get atrophy of the lymphatics everywhere, right? No, please go back to the previous slide. Okay, let the child come. Go ahead. Next one.
Moving head to toe examination. The head appears large when compared to the body. AF is still open.
What does it imply? Head appearing large. He said head appearing large. What does it imply? In general, the head is the last portion of the body to be affected in malnutrition. Okay, right.
The anterior fontanelle is open, about 1 into 1 centimeter, admitting 2 fingers breadth. It has undergone a fibrous closure. The posterior fontanelle is closed. There is no overriding of sutures. There is no, the hair is
go ahead.
Hair is sparse, lusterless, brittle. There is no facial dysmorphism. There is frontal bossing with sunken eyes. There is rachitic rosary and Harrison sulcus. BCG scar is seen in the left arm. The abdomen is distended with the umbilicus is pushed down. External genitalia are normal, and there is no active seborrhea or ear discharge.
Go ahead.
Vital signs. Temperature is 100 °F, measured in the right axilla. The heart rate is 140 per minute. regular in rhythm, normal volume, all peripheral pulses are well felt. Respiratory rate is 60 per minute. Abdominothoracic type of respiration. There is a grunt, subcostal and intercostal retractions is present. Blood pressure is 90 by 60 millimeters of mercury, measured in the right upper limb in the supine posture.
Okay, go ahead. You completed this. Yeah, we'll take up the anthropometry up. Let me focus this. It looks chronically yeah, it does look it does look chronically ill. There is absolutely no disagreement on this. And most importantly, what is striking you is the severe wasting. I think that is to be said right in the beginning. As you can make out, there is definite rachitic rosary on either side. Yeah. And did you hear a grunt? Are all of you convinced that there is a grunt in this child? What is grunt, Vidya? What is grunt? What is grunt? Define grunt. Yeah, yeah. It is. How is it produced? Yeah, when the child is expiring air forcefully, it suddenly closes the glottis. Is it happening in this infant or child? There is no grunt. You must be careful. There is no grunt in this child as of now. There is no noisy breathing per se. Right? Very important is the child looking active?
Yes, sir.
But for the respiratory distress and malnutrition, it looks fairly active, moving the limbs nicely, looking around, in fact trying to pick the catheter in the nostrils, right, and also rubbing the eyes, right. Okay, go ahead. You said rachitic rosary present. Is there widening of the wrist? They are widening of the ribs, or is there double malleolus? Other signs of rickets?
No, sir.
Lower down. Please focus lower down. Zoom. Yeah, there doesn't seem to be any widening, either of the wrists or of the ankle. Right. Go ahead. Then what else? Hair is sparse, right?
Sparse.
Fine.
AF is open, fibrous closure, admitting 2 fingers.
Eyes are bright. There is no vitamin A deficiency obvious.
Frontal bossing is there, sir. Buccal mucus, cheeks are wasted, sir.
Okay. What about the teeth of the child?
2 lower central incisors are present, sir.
Yeah. Is it normal?
Normal, sir.
Normal. Okay. Is it appropriate for 15 months?
Yes,
Not
sir.
bad.
Not bad,
Not
sir.
bad.
So
Growth retardation is occurring. The upper age limit for delayed eruption
1.5
is
years,
13 months.
13
It is
months.
erupted. Fine.
Yes.
Then
rachitic rosary, Harrison sulcus, abdomen is distended, umbilicus is pushed down.
okay.
sir.
What, please? There are 2 or 3 important points in the physical examination. You find that is there elan-asa movement in this child, Vidya?
He was not able to appreciate.
Not able to appreciate. If you closely observe, both the ala and asa appear to be moving minimally. That doesn't occur in any child who has got a metabolic acidosis. Second thing is, we think this child is having deep sighing respirations or shallow respirations. Simple. It doesn't seem to have. Can you focus, please, on the child's chest for a moment? You see here, though there are retractions, it is not that it is taking in lot of air in and out. It is a shallow respiration. So the presence of movements of the ala nasi and the presence of shallow respiration, more so with hypoxia, tells you that this tachypnea is due to a primarily a respiratory disease. Right? Sister, close. Go ahead. Right? Finish your examination. Nervous system, then what else? Cardiovascular system. Yeah. What do you look for in the cardiovascular system in a child like this? Specifically, what did you look
Anemic
for?
murmurs.
Yeah, you can have a systolic murmur. Don't say hemic murmur. There is no such thing. There you can get a systolic murmur. Sometimes even a venous hum in the child who is sitting due to anemia. We'll go to the question later. Yeah. Next.
Cardiovascular system examination.
Then you can always, suppose this is a chronic lung disease, what do you expect in the cardiovascular system?
Pulmonary area.
Loud pulmonary second sound, pulmonary hypertension
Ejection systolic murmur.
can be there, right heart failure signs may be there, right? Okay. Now what's your, can you sum up the whole thing in one sentence and give a probable diagnosis? Yeah.
This is a child with lower respiratory infection, probably lung parenchymal disease, with acute on chronic undernutrition, with vitamin D deficiency, anemia, and visible wasting. It can also be called as severe acute malnutrition.
Okay, right.
The cause for the undernutrition is probably related to the abdominal pathology, sir.
Abdominal pathology. What abdominal pathology is this? Why do you say that there is an abdominal pathology in this child which is causing the failure to thrive?
Presence of abdominal distension.
Okay. Can you not get abdominal distension in a child with rickets?
Yes, sir.
Then there is no organomegaly. Pardon? Okay, anybody in the audience who wants to give a complete diagnosis for this child? Okay, we'll take up one by one. One is, we have another 10 minutes more, we'll quickly finish. One by one, if you take the list of problems which Vidya was able to identify, definitely there is failure to thrive. Definitely there is failure to thrive, and this is chronic. This is chronic. The history suggests that the child is not getting enough proteins and calories. But I think the 1/3 calories is deficient, protein deficiency is not very much, but still the child has lost weight, leave alone not gaining weight. The very fact that this child has lost weight indicates it is much more than PM. Agreed or not? This is a failure to thrive. And history suggests that this disease, whatever respiratory disease that this child is having, is of a, from the history, is only short duration, maximum 2 to 3 weeks. So you can't blame the respiratory disease for the primary problem. So the presence of rickets in this child, what does it indicate? Presence of rickets in a child who has got malnutrition indicate that there might be a malabsorption in this child, and this malabsorption might be in the which portion of the intestine?
Small intestine.
Small intestine. It could be in the small intestine, because there is no diarrhea, there is no bloody diarrhea in this seeing. There is not much of lower abdominal distension, indicating that this is likely to be a small bowel. Do you think this is a small bowel problem which is surgical?
No, sir. No, sir.
Surgical. Can you have a small bowel problem where there is abdominal distension with malabsorption of diarrhea and vomiting? Can you have or not? You can have, or you can very well have. You can have, which can cause anemia, which can cause vitamin D deficiency, A deficiency. We don't know whether the child has received vitamin A in the past, could have been corrected. That is possible. But only thing is do you think this is protein losing enteropathy?
No, edema is not.
Yeah, the absence of edema makes protein losing enteropathy unlikely. So this is likely to be a small bowel problem resulting in malabsorption, resulting in failure to thrive. If it is causing that, how do you connect that and the respiratory problem? How do you connect that and the respiratory problem?
Respiratory problem is due to infections.
Respiratory problems. All of you are sure that this is due to infection?
15 days.
No, do you think this is, okay, he says respiratory tract infection is there. Do you think this is bacterial or viral or fungal or protozoal? Do you think this is, anybody can answer? It's extremely unlikely to be bacterial for the simple reason this hypoxia has been lasting for more than 2 to 3 weeks. 3 weeks. So this indicates that this is likely to be a chronic interstitial pneumonia. How do you connect the interstitial pneumonia and the bowel malabsorption? Yeah. Could be due to a non-infective or a disorder of the mucous glands, particularly cystic fibrosis. That is one possibility. Is cystic fibrosis a possibility in this child? Very much a possible. Very much possible. The only point is there is no clubbing, there is no steatorrhea in it, there is no history suggestive meconium ileus, but the very fact that there is something happening in the abdomen and some chronic problem is happening in the lung, you have to think in terms of cystic fibrosis. That's one. Second is this immunodeficiency?
Yes, could be.
Is this immunodeficiency?
Could be.
Okay. If it is immunodeficiency, do you think this is acquired immunodeficiency or congenital immunodeficiency? Primary or secondary?
Secondary.
Secondary.
Primary.
Could be either. Could be either. The very fact this child was all right up to 6 months could indicate that this is a HIV infection, which can explain everything. HIV infection can cause chronic wasting without any other manifestation, and this interstitial pneumonia could very well be a manifestation of chronic HIV infection, the most notorious being, what is the interstitial pneumonia which is common in HIV? Lymphocytic interstitial pneumonia. That can explain everything. That is one possibility. The second possibility is that even at B cell defect, the first few months of life the infant will be absolutely normal because of the transplacental passage of immunoglobulins, and the child can start having symptoms. But the only point against this child not fitting into immunodeficiency is that nothing other than the present episode of respiratory infection has happened in this child. No ear infection, no diarrhea, no hospitalization. That makes it unlikely. The possibility cannot be ruled out. But one thing you can say, this is not likely to be a severe combined immunodeficiency. It cannot go on like this for 1 year, 15 months without any clue. Because a B cell defect is not ruled out. A secondary immunodeficiency like HIV is not ruled out. Right? That is one. What other possibilities are there? What other possibilities are there? Pardon? Celiac disease. Celiac disease. Yes. If any child who has got anemia, abdominal pain, failure to thrive, short stature, with some disturbance in the bowel habits, one has to think of celiac disease. In this child, that is why I said in the beginning, diet becomes very, very important. It has to be kept in mind. It has to be kept in mind as a possibility. What next? What next? What next? Somebody put tuberculosis. Is tuberculosis likely, Vidya, in this child? Is tuberculosis likely in this child? Somebody will say tuberculosis is like Amitabh Bachchan, it can take any role, it can present as anything like HIV. Possible? Yeah. 2 or 3 points. One is, in our country tuberculosis has to be thought of. There is no doubt at all. There is no doubt at all. The points against tuberculosis are, one is, it cannot go on like this for 9 months. 9 months with only wasting, the child without any other manifestation, extremely unlikely. Second is history of contact is not present because that doesn't rule out tuberculosis. Third is that clinical examination. If it is tuberculosis, you think this is tuberculosis in the lung or tuberculosis in the abdomen or miliary tuberculosis? If at all you think of, it might be a miliary tuberculosis, right? But then even for miliary tuberculosis, right, it is very difficult to make a clinical diagnosis unless of course you look at the fundus and find choroid tuberculosis. Very difficult, very difficult. Miliary tuberculosis in this child is not ruled out. It can behave exactly like interstitial pneumonia with abdominal dystonia, etc. Could it be abdominal tuberculosis? Abdominal tuberculosis can present in many forms. The forms depend on where the pathology is. For example, if you have a lesion in the bowel, in the intestinal wall, tuberculous enteritis can cause chronic diarrhea or diarrhea with alternating constipation. That can happen. It can present as malabsorption. Protein losing enteropathy can be caused by intestinal tuberculosis. Sometimes it can present as mesenteric lymphadenopathy or ileocecal tuberculosis. Rarely it can present only as ascites. Still rarely it can cause subacute intestinal obstruction. Sometimes you can get perianal abscess. Rarely you can get hepatobiliary tuberculosis, granulomatous tuberculosis of the liver can occur. You can have portohepatitis glands causing obstruction to the portal system, resulting even in obstructive jaundice, right? Anything can happen in tuberculosis. But in this child with this sort of presentation which is going on for 9 months, tuberculosis is not likely, but it is not essentially ruled out. But then the last point for tuberculosis is that this sort of hypoxia going on for 2 to 3 weeks, okay, is very, very unusual in tuberculosis. The very presence of hypoxia, unless there is massive pleural effusion, hypoxia per se as a manifestation of pulmonary tuberculosis in the absence of severe pneumonia, pneumothorax or pleural effusion is extremely unlikely. Of course, you can have hypoxia sometimes if you have a mediastinal node causing obstruction like foreign body. That's very, very unusual. Any other possibility? Any other possibility other than this? Could this be alpha-1 antitrypsin deficiency? No, no, so early wasting, only lung manifestation, no liver manifestation, extremely unlikely. Could it be intrauterine infection? The birth weight was excellent, the baby was absolutely normal until 6 months. This is not likely to be intrauterine infection. If it is interstitial lung disease as agreed upon by most of you think it is. What do you think is causing the interstitial lung disease in this child? What are the common causes of interstitial lung disease in this child? Basically, interstitial lung disease is commonly secondary to infections or chronic aspiration or so many hereditary disorders, metabolism of surfactant protein as well as glycogenosis, lipidosis, etc., and the so-called hypersensitivity pneumonitis as well as idiopathic pulmonary fibrosis in pediatrics is extremely uncommon. Okay, just to save time, I'll tell you what happened to this child. Okay, are there any signs in till what age we call failure to thrive or PEM? I mean, what is the answer? Failure to thrive, what age? I was surprised. I got so many answers in the references. By and large, the term failure to thrive contains 3 words or restricted to 3 years of age. By and large, by convention. There is no harm in a 3.5-year-old child you use the term failure to thrive. It's a concept. It indicates to you that this child is failing to gain weight, whatever the age. That's one. Second is PEM. The WHO definition as well as the UNICEF definition restricts PEM to 5 years. But I can also tell you in the exams, many examiners don't mind if you use the word PEM even in a child who is 5.5, 6 years, 7 years old. But by and large, you use the term underweight, obesity or overweight in children above 5 years rather than PEM, or use the classification. Last question, are there any signs of occult or subclinical hypocalcemia in this child? I mean, what do you mean by occult or subclinical hypocalcemia? Irritability, seizures. Other signs of hypocalcemia are very difficult. What is that sign called? Yeah, I forget. Sorry, we rarely elicit in pediatrics, particularly in a young child. But of course, irritability is the hallmark of hypocalcemia in a young infant, which is not there in this child. Right? That is not there, right? So at the end of it, I'll tell you what we did to this child. This child came to us in the OPD, failure to thrive. We did the investigation. They didn't do the investigation. They landed up in respiratory distress, went to the ICU, came out after a course of a stormy course with antibiotics and supportive measures. So far we have done immunoglobulin workup, we have done HIV workup, we have done metabolic workup, and X-ray has been essentially normal, ultrasound is normal, liver function, renal function has been essentially normal, and we have not had a diagnosis except that this child has been proven to have vitamin D deficiency. Definite low vitamin D with parathormone, with hypocalcemia, with hypopastemia with markedly elevated alkaline phosphate, proving it is rickets. We have treated the vitamin D deficiency. We have given antibiotics for about 2 weeks. We have ruled out, I would say, common infections and immunodeficiency, tuberculosis. We have worked up so far. So far the workup has been negative. There have been no clues radiologically or in the ultrasound of the abdomen, and after getting the history, we feel that there might be a small bowel malabsorption which is responsible for this failure to thrive and vitamin D deficiency and an interstitial lung disease incidentally. What we plan to do is to do a, so what important investigations will you do other than the routine? We have done everything. What next? What next? You'll have to do a upper GI endoscopy and probably a colonoscopy to look for a bowel problem. If that also doesn't give a diagnosis, next is lung biopsy, right? Okay. There are no questions. We will. Are there any questions from you, all of you? I know you must all be tired. I had to pull it along because I started at 2:40. They said 2 hours, 2:30 to 4:30. I wanted to be very disciplined, so I started at 2:40. Now it's 4:40, right? One question from the audience, and I must compliment Vidya for presenting this extremely well. And since like you're a brilliant student, you present like this. Approach is more important than the contents, right? Okay. Thank you. Please remember that the next meeting is in Sion Hospital at 6 p.m. on the 9th of October, Mumbai. Okay. Thank you very much. Let me thank the Alembic company managers for helping us with this. Okay. Hopefully we'll have it sometime in October again. Thank you.